Welcome to the MS-Perspektive podcast, Perspective with a K as I'm German. I'm Nele von Horsten, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins. Thanks for tuning in again and welcome to episode number 95, Hidden Challenges, Exploring Smoldering MS with Professor Dr. Gavin Giovannoni. Gavin Giovannoni is professor at Barts and the London School of Medicine and Dentistry in London in the United Kingdom. And he is a very famous MS neurologist. So please enjoy the interview. Hello, Gavin. It's such a pleasure to have you on the show. And thank you very much for taking my invitation and coming and joining me in the podcast today.
My pleasure. Looking forward to it.
And before we actually start with the interview, it would be lovely if you could introduce yourself to the audience so they know who is with me on the podcast today, for the few ones who don't know you yet.
Yes, I'm an academic. In other words, I do research and I'm a neurologist. I'm based in the Royal London Hospital, which is an NHS hospital, and I'm also based in Queen Mary University of London, where I do multiple sclerosis research. Your audience may recognize my accent. It's not English. So I come from, originally I grew up in South Africa.
Thank you for the introduction, Gavin. So today we want to talk about smoldering MS. What is smoldering MS and how does it change our previous understanding of the disease?
I mean, smoldering MS is a term, it's evolved over the last 6 to 8 years, but it's a concept to try and capture the part of multiple sclerosis that we're not measuring using clinical outcomes and MRI. So most people think about multiple sclerosis as having relapses or attacks, and we measure those clinically. And on MRI, we get these new lesions that come and go. We call that MRI activity. And those two components of multiple sclerosis are what we call the inflammatory component. And we now know that when we actually put people with multiple sclerosis on therapy and we stop them having relapses and stop them having MRI activity, a significant number of them will still get worse. And that's called PIRA, progression independence of relapse activity, which is what we measure in trials every 3 months by doing disability scores, whatever. But in addition to that, there's also evidence of smoldering MS that's not picked up by our outcome measures in clinical trials. And so the smoldering MS umbrella is to try and capture all the components of worsening MS that's not detected using our standard outcome measures. And most people with multiple sclerosis are aware of this. They often go to see their neurologists for their 6 or annual follow-up appointments, and they're told, you're relapse-free, your MRI is stable, therefore your disease is under control, go away. And most people don't feel satisfied with that because they know that things may be getting worse. And that's what we're trying to capture, is that that worsening that we're not measuring with our standard outcome measures. And there's a whole lot of different processes that are underlying smoldering MS.
Yeah, thank you for this explanation. And I guess many of the listeners know what you are talking about. They feel it's getting worse and the doctor is not realizing what is happening. So can you explain the underlying mechanism and pathology of smoldering MS and the challenges in diagnosing?
Yeah, so what we think there are quite a few mechanisms. So one of the things is that the inflammation that's driving MS becomes compartmentalized, they call about it. It's actually happening within the brain and spinal cord. And that's driven by a group of cells called the microglia. These are little, they actually derive from white blood cells that go into the brain when the brain's developing. And they produce inflammatory mediators and chemicals that damage, nerve fibers. So that's what we call the hot microglial component, and there are treatments now to try and switch off these microglia. Also, inside the brain and spinal cord of people with MS, there are these cells called B cells and plasma cells. These are the cells of the immune system make antibodies. And we think those antibodies are actually part of what's driving smoldering MS. They attack the nerve cells in the myelin causing ongoing damage. And our current treatments don't really get into the central nervous system to kill these. So we now have to develop a new class of therapy, or therapies, I should say, go into the brain to try and scrub the brain clean of these B cells and plasma cells. And there is a biomarker when we do lumbar punctures and take the spinal fluid out, and we find these things called oligoclonal bands. These are immunoglobulin bands, and that's actually a marker of these B cells and plasma cells making these antibodies. So in the future, we may want to, scrub the brain clean and clear the spinal fluid of these oligoclonal bands. Then there's persistent demyelination. So we know that MS causes the myelin, the insulation of nerve fibers, to be stripped off. And although some of those nerve fibers can remyelinate, in some people remyelination doesn't progress. And so persistent demyelination is another mechanism. So therefore, there's this rationale to create remyelination therapies. Another component is what we call energy deficit. So when you're actually conducting down a demyelinated nerve fiber, it takes much more energy to stick the electrical signal down the nerve fiber. And in addition to that, the mitochondria, the little energy, the little component of the cell that makes energy, is actually not working as well in people that have got inflammation in the brain and spinal cord. And so there's an energy deficit. So there are potential mechanisms to try and enhance energetics in the brain. And that's where oxygen therapy and things to try and promote mitochondrial function are in. And then there's also premature aging. We know that what protects us from aging is what we call brain health. How much reserve capacity our brains and spinal cord has. And we know that multiple sclerosis reduces that, because by causing death of nerve fibers and the axons, your reserve is reduced. So as you get older, you start seeing aging happening earlier. So the aging mechanisms come in. And we don't really, I'll be honest with you, we don't really have anti-aging treatments at the moment. We have a clue that brain health is important for anti-aging mechanisms, exercise in particular, but there's things around diet and sleep, preventing what we call comorbidities, people getting high blood pressure, diabetes, all those things that are poor for brain health also play out in people with MS. So this is one of the reasons why it's very, very important for people with MS, not only to just focus on MS, but also to focus on general health, because general health is important for the brain and spinal cord. So there's different components that we think are driving smoldering MS.
Okay, thank you. Yes. And I know it's a hard question, but what percentage of people with MS are thought to have smoldering MS, and how can early detection benefit the patient's long-term outcome?
Well, we don't know. I think it's important not everybody does have smoldering MS, because we do know that some people come to post-mortem, they die in old age, and they've got MS on their brains and spinal cord, but they've never developed MS in life, never been diagnosed. So whatever's causing multiple sclerosis, that person's immune system must clear it. And then there's some people that end up, old age with no disability. So, they've had MS their whole life and they don't get worse. In retrospect, we call that benign MS, but we don't like that term because it's very difficult to predict who's going to have benign disease. So to be honest with you, the proportion of people that end up with benign MS was very low in the past, because most people ended up with disability. But I think now that we've got effective treatments, we're beginning to see the proportion of people ending up in old age with less disability is increasing. So I do think our treatments are working by preventing relapses and MRI activity, but they're also having an impact on smoldering disease. And I would be giving you an incorrect figure by giving you a definitive figure, but I would estimate in people with established MS, about 30 to 40% of them now will get to old age without disability. And in the future, we want that to be 80 to 90%. And this is why detecting smoldering MS is important, because there's going to be a new class of therapies coming out, that will be potentially, people will be potentially eligible for, that would target smoldering mechanisms. So we're anticipating in the next 12 months a new class of therapy to come out that will work much better on smoldering MS than the current therapies. So there is a incentive, I think, going forward to detect this. And also, I think people with multiple sclerosis don't want to get hoodwinked. They want to know about this because they're experiencing it, and then they ask the question, well, what can I do about it? And so obviously therapeutics, using a disease-modifying therapy is one strand, but also focusing on all the other things, being aware of what else you can do to tackle smoldering MS is also an important part of MS management. So, rather than put your head in the sand and ignore it, I think it's much better to confront it and understand what's going on. Maybe you disagree with me. I know there are some people who don't want to know about this, but that's a personal choice. If they don't want to know they've got smoldering MS, then they shouldn't be told.
Yeah, of course, and it's everybody's choice. But my motivation to do that podcast is get people informed so they can do whatever it is possible to stay as healthy as possible. And of course, people can decide not to listen to the podcast or other things. And going to the dentist, getting your vaccinations, being sporty, healthy lifestyle. There are so many little small components we can do. And I prefer to choose all the little modules to get to end up in the 30 to 40% range, and in the future hopefully 80 to 90% range without disabilities when I'm 80, 90 years old. Would be lovely.
So another thing that people tend to just live with, is infections. So we know that people with multiple sclerosis get bladder problems, and they're much more likely to get recurrent bladder infections, and some of them may get recurrent chest infections because of swallowing problems. And some of them may have inflammation in their gums. We call that periodontal disease. And some people get recurrent sinusitis. But there is also evidence now showing that if you get recurrent systemic infections, that causes smoldering MS to speed up. And, rather than live with your bladder infections, because some people just seem to say, I'll get a bladder infection every 6 to 8 weeks and I'll just get antibiotics and that's fine. Well, I don't think that is acceptable. There are really good strategies now to prevent people getting urinary tract infections, and also to prevent themselves getting severe chest infections. So, it's also engaging with other healthcare providers to stop infections. It's another component of treating smoldering or preventing smoldering MS. And I'm always shocked when I get new patients to hear from them how many of them just accept recurrent infections. And I say that's not, you don't have to live with recurrent infections. There's a lot we can do. That's another message to get across.
Absolutely. So there was one very interesting new information for me when you were at the Advanced Symposium in Dresden, and that was that at one point MS was made an orphan disease because they created the terms of relapsing, remitting, primary progressive, and secondary progressive. Can you maybe dive a little bit into what happened back then and why it is important to be aware of the fact that there is, at the end, just one MS with different, let's say, parts that are more active at a certain time or not?
Yeah, so I mean, the concept here is how do we define diseases? So when you define diseases in the medical field, I'm not talking about psychiatry, they do it a little bit differently to us, because psychiatrists tend to talk about symptoms phenomenology rather than, in medicine, we talk about a clinico-pathological correlate. So when you use what we call medical philosophy framework, MS is one disease. It's got a clinical phenotype, what you see clinically, and it's got a pathology that goes with that, what you see under the microscope. And when you do the clinical pathological correlate, there isn't any difference between the different types of MS. They kind of fall into the same spectrum. But what happened was to get drugs licensed for a disease, or to help incentivize the pharmaceutical industry, various governments created these things called the Orphan Drug Act. So this is to try and encourage drug companies to develop drugs for diseases that affect small numbers of the population. And the Americans were the first to do this. The FDA, the Food and Drug Administration, put forward an Orphan Drug Act that goes back to the late 70s, early 80s. And the Orphan Drug Act defined an orphan disease as a disease that only affected 200,000 or less Americans. And so when you actually look at MS, there were more than 200,000 people with MS in America at that time. So what they decided to do, and this is political, this is just a business political decision, they decided to actually slice up MS initially into 3 diseases: relapsing, remitting, secondary progressive, primary progressive, and then each grouping would have less than 200,000. And the reason for doing that is to get interferon licensed with one trial. And that's how interferon beta got licensed on one trial. And it was called, and because MS was an orphan disease. So it was essentially a fudge. It wasn't based on biology. It wasn't based on pathology. And then they added a fourth group called clinically isolated syndrome to that. And I think when the diagnostic criteria change, they'll take asymptomatic MS, radiologically isolated syndrome, and create another category. So you've got these little pigeonholes to define what the disease looks like, and they're not really different diseases. So, and the reason why I say this is because you can actually push people from one type to another type. I'll just give you an example. Somebody may have relapsing remitting MS, and you put them on a very effective disease-modifying treatment, and you stop them having relapses, and they're getting worse because of smoldering MS. That's progressive MS. That's what we see, worsening independent of relapse activity. And similarly, you can take somebody who's got primary progressive disease, and if you give them a certain type of immune stimulant, you can actually cause them to have relapses. So you can push people along the spectrum. So I think, my interpretation of what we see clinically is you've got MS, and the real disease is smoldering disease. And then what you see from a clinical perspective is the inflammation that occurs from the systemic inflammatory response to the disease, whether you can have relapses on MRI activity. And this analogy doesn't only apply to MS, it happens in many other diseases. We see this, what we call a clinical phenotype, a spectrum, based on how the immune response responds to what's causing the disease. And so, I'm firmly in the camp, and I think actually most people now, I wouldn't say most, but a large proportion of the MS community, the research community, are now beginning to accept that MS is one disease, and that these categories, putting people into these little pigeonholes is artificial.
Yeah.
And so. And the reason why this is important is because it has implications for treatments. People think that treatments don't work in progressive disease. Well, I think that's wrong. They do work. They just don't work as well because the people with progressive disease are much older and further and more advanced. So you don't see the treatment's effect being that prominent compared to early MS. It's just a matter of where you are on the course of the disease.
Yeah. So why is it important to leave behind these terms of RMS, SPMS, and PPMS when looking for personalized treatment, where we luckily are moving towards more and more?
Yeah, so I think what will happen is you're going to be labeled, or people are going to get given a diagnostic label as having multiple sclerosis. And then on top of that, they're going to ask, do you have any evidence of inflammation, focal inflammation? Or you're having relapses on new lesions, and then you'll have to have that treated with a particular class of disease model, an anti-inflammatory. And then if you've got evidence of smoldering disease, you're going to have therapies that target those smoldering processes I talked about. And that's going to open up this new therapeutic era where we're going to be using combination therapies, not just one treatment. At the moment, treatments are monotherapy. You can only take one therapy at a time. But I think going forward, we're going to be doing combination therapies to tackle both processes.
Yeah. So what are the current treatment options available for smoldering MS, and how effective are they in managing the disease worsening? I mean, you already said a little bit, but you don't see it much because the worsening is more prominent.
Yeah, so we don't have any therapies that are licensed specifically for add-on smoldering MS. There's a new class of drugs called Bruton tyrosine kinase BTK inhibitors. The first one was only tested in relapsing remitting disease, and it wasn't shown to be better than teriflunomide, a licensed therapy, so it never went forward. But tolebrutinib, which is the second trial, there were 3 trials to report out, shows that the drug actually works above and goes beyond focal inflammation and actually slows down smoldering components. So that's potentially going to get licensed. So somebody who's on an existing DMT, for example, and is getting worse, would potentially be eligible for tolebrutinib. But it's not. I'm saying this I'm not 100% sure what the European Medicine Agency will do. The agencies may have different opinions, but I see the American FDA has fast-tracked the approval process for tolebrutinib, so they probably will get it in the United States earlier than the European community. So that will be an option in the next 12 to 18 months. And then there are other BTK inhibitors after that. There are 2 big trials. There's one called fenebrutinib, and then there's one called remibrutinib, and there's one after that as well. So that's that. And then in addition to that, there are other therapies being tested. So there are drugs that are being repurposed from the oncology field that go into the brain. There's proteasome inhibitors that hopefully will kill the B cells and the plasma cells that make the antibodies. Cladribine is one of the therapies that are licensed for treating relapsing MS. We have evidence that because it's a small molecule, it does go into the brain and it does kill B cells and it does reduce the amount of antibody in the brain. So that's actually a drug that possibly has an effect on smoldering component in addition to the inflammatory component in the periphery. So clearly there are. This is new. This is really new in the field, but there's going to be treatments where we will target smoldering MS. And then at the same time, people with multiple sclerosis have to engage with the non-MS targets. Yeah, like I mentioned to you, now there's something. There's certain things that are really, really important. So I don't know how aware your audience is of social determinants of health. So these are the things that affect you socially that impact on brain health. So things like social isolation and loneliness. Okay, these things are really important, and there's preliminary evidence suggesting that people that have got who are socially isolated or lonely, in other words, they don't have enough social interactions, their social capital, do worse. It's it's well known that these social determinants have an impact in mental health, particularly, but they also look like they have an impact in MS. So part of our responsibility as healthcare professionals is to try and identify people that have what I would call modifiable social determinants, and then use different types of treatments. There's a thing called social prescribing. Now, I don't know, in Germany, is social prescribing a big thing or not?
I'm not sure. Social prescribe. I mean, I had Anthony Feinstein on the podcast talking about the Codex study, where they found out how important the social component is. But I'm not sure what social. So the
example would be if somebody is socially isolated, you could actually see what they like, and then you can give them subscriptions to art classes, music lessons. They can join. They can join gardening classes, walking clubs. But the important thing about these activities is not so much the activity; it's the fact that they go and do it as a group, and they become and they have interactions with other people, and they form friendships, and they regrow their social networks. So it's more about reconnecting people that have become disconnected from their communities. The church, religion is very important. I'm not saying I'm going to promote religion here, but one of the things about religious groups is they tend to maintain social capital, because by participating in a religious group, by going to church and involved in religious activities, you are keeping that component of your social determinants healthy. It's what I call social health. And we can't underestimate social health. I see it all the time. When people lose motivation, then it impacts on mental health, and all those things make things get worse much more quickly. So this is why I have this philosophy of marginal gains. Trying to fix all the little things adds up to big changes, and that also means looking at social health. So it's social health, metabolic health, making sure we prevent comorbidities or treat them aggressively, getting people who smoke to stop smoking, getting people who are not eating well to eat healthily and lose weight if they're overweight. All these little things make a difference. I've got examples of people that have lost weight by doing exercise programs and going on certain diets, and seen their disability scores improve, not because their MS has improved, simply because their physical health's improved. So, you can improve disability by focusing on, general health.
Yeah, absolutely. And I just had to think of, I'm actually non-religious, but when I was living in Chicago, I did an architectural tour, because Chicago has beautiful architecture. And I was invited by the parents of the lady who was doing the architectural tour to join them for Christmas. And of course, it was totally lovely to be together with a family, even though it was not mine. And they did that because they were very much religious and living up to that idea of helping out the others, inviting them, joining together. And it was very lovely to join for a Christmas, a family I didn't know, because I'm very close with my family. And that can be so important for you and your health and your well-being, and absolutely agree on that.
And I mean, one of the problems about this component, what I call the non-MS targets, is sometimes they form vicious cycles. So if somebody's social health deteriorates, they lose their job, they get divorced, they split up with their partner, and they end up alone. Then that also feeds into worse mood, depression. It affects their sleep. The elephant in the room for MS. I don't know if the Germans use this term, the elephant in the room. Often the elephant in the room is missed because you don't see it. Is sleep. Sleep hygiene is shocking in the average person with MS. When you do a survey, you find how badly people with multiple sclerosis sleep. Now, there's a whole lot of reasons why they're sleeping badly. Often it relates to bladder problems, leg spasms, pain, depression, anxiety, too much alcohol at night, sleeping in the day. And, there's a whole lot of reasons why people have poor sleep. And there's also potentially obstructive sleep apnea, which is quite common in people with MS. And you can't fix your MS if you're not sleeping properly. So one of the indicators, I think one of the things we should be focusing on is how do we get people with MS to sleep better. And then what happens is you break those vicious cycles. All of a sudden they wake up in the morning feeling refreshed, and they don't feel as fatigued. Their energy levels go up, their mood improves, everything improves if you fix sleep. And I did a survey. I've done a few surveys around this, and it's about 80% of MS people with MS have a sleep problem that they feel is a problem. That's 4 out of 5. That's much higher than the general population. The general population, that figures in around about 30%. If you go to people that are, in inverted commas, don't have a disease, the healthy general population, about a third of them will complain of intermittent insomnia, for example. So it's much, much higher than the general population. So this is something I'll be interested to know from you. Just is your sleep? Would you say are you satisfied with your sleep hygiene?
Yes. Having a baby is not so easy, but she is sleeping now here when we have the interview. And of course, as I'm breastfeeding, which hopefully will keep her away from many health-related issues, makes my sleep, let's say, challenging. But I do then sometimes a 10-minute nap during the day. Normally, I don't have to do it because I have the hormones. When you do breastfeeding, you have the hormones. But normally, I can sleep very well. And I just have issues with sleeping when I have psychological problems where I really was thinking about that problem. So I don't know. There was issues.
So that's called rumination anxiety. So people worry about things and they ruminate. They get these intrusive thoughts at night. It's very common in MS, rumination. So the psychiatrists talk about it. It's ruminating. So you get this intrusive thought that it happens in normal people, and there are ways to deal with intrusive thoughts. You have to practice mindfulness, and if you get quite good at mindfulness, you can switch those thoughts off, and it helps sleep. There's some incredibly good sleep apps now that have been made, and one of them is actually licensed in the UK by the NHS. NHS pays for it. I think the subscription's about £45, I'd say €45 a year, and it's cheaper than taking sedatives, and it's much healthier for you than taking sedatives. And the results are almost as good as sedatives, and it works long term as well. So I urge your listeners, if they are having sleep problems, to get them investigated by their MS team. And one of the treatments would be to use it's called cognitive behavioral therapy for insomnia. The CBTI is the term they use for that, and it involves mindfulness and meditation techniques to help you sleep.
Okay, great. Yeah, I was using back then, that's now like 13, 14 years ago, Mindfulness by Jacobsen, I think it was in Germany. The guy was quite popular, but yeah, can help a lot. So let's move on a little bit to the biomarkers. How can your biomarkers, like advanced imaging techniques, aid in monitoring and managing smoldering MS? Because, as you said, it's not so easy to really find out who has problems with smoldering MS.
So unfortunately, the current MRI protocols. When you go and have your MRI scan every 12 months, some places I know in Germany sometimes they do it every 6 months in some centers. They just really look for new lesions. They don't really look for the other biomarkers. So this is where what we would call advanced imaging techniques come in. And they can measure brain volume, for example, the size of the brain, and they can show that people with multiple sclerosis may have what we call accelerated brain volume loss. Another term is atrophy. Just to say to your listeners, that happens to normal people as well. So from the age of about 35, it's downhill. All our brains shrink. So it's part of aging. People with multiple sclerosis seem to have a much faster rate because of the MS on top of aging. And so, there are now algorithms for measuring. Now, this is where people with multiple sclerosis need to be very aware. Very, very few centers measure brain volume loss. And the reason is it's not part of the standard reading. The MRIs have to be taken and analyzed in a software program offline, and that takes time and resource. There are companies now that provide the service, but again, it's a service and they have to charge for it, and healthcare payers, insurance companies, are often resistant to pay for that. And I suppose at the moment, without treatments to target smoldering MS, knowing if your brain's shrinking more than it should be is maybe not a good thing unless you have a therapy for it. But that's one of them, is brain volume. What will happen in the future, certain lesions get bigger slowly. So most lesions in MS, when you have MS and you get put on a treatment, shrink, but a small number, about 5%, about 1 in 20 lesions, will continue to get bigger slowly. It's called a slowly expanding lesion. That's smoldering MS. Those lesions we know are much more destructive and are causing problems. So that could potentially be measured also in the future. And then there's also blood markers. So people can measure this protein called neurofilament. Neurofilament is released from damaged nerve fibers. And if you've got raised neurofilament levels, it means your MS is active. And that's over and above. It provides more information than just measuring relapses and new MRI activity. So there's blood markers. And some centers, our center, for example, has been using neurofilament levels as an adjunct, as an addition. We very rarely, and I'm saying this, we rarely make decisions based just on neurofilament level. We use it with the MRI and the clinical as to give us a much bigger picture to make a decision on treatment. And there are other biomarkers emerging. There are other proteins that can be detected in the blood that will come in the future to measure smoldering MS. So, and then there's more sensitive clinical tests. So, cognition is one of the big components of smoldering MS, is worsening. And our current clinical scoring systems don't monitor cognition. So some centers now do these, 6 monthly or 12 monthly cognition tests, and they can pick up worsening cognition. Now, again, some people with MS don't want to know that their cognition is worsening. Some people just like to adapt and cope with it. But if your cognition is worsening, it may mean that you should be eligible for a better therapy, for example. There's some recent data that came out at our ECTRIMS meeting from Australia, from MS-Base, which is a big international database registry of patients, showing that even if you are free of inflammatory activity, but you're getting worse and you switch to a more effective therapy, you do better than staying on the existing therapy. So I think there's a logic for measuring using more sensitive clinical outcomes to see if you are worsening, because it may, nudge you towards a more effective therapy.
And how is it in the UK and in Germany? It's quite a problem to have. We don't have enough neuropsychiatrists to do that testing. That, let's say, more advanced testing. I did it once, and I'm in all these tests here in Dresden. So my brain atrophy is getting checked, NFL levels are checked, all these things. But that is because it's a universal MS center. So of course that's not the normal setting, but we really have issues with the amount of neuropsychiatrists.
Yeah. So what's happened now? The neuropsychologists have put together these small batteries that can be done without a psychologist. So they screening tests. They're not good enough on their own. So there's one that's the most commonly used, is called this SDMT, the symbol digit modality test. It's essentially a cognitive reaction time. You have to think about recognizing these two symbols and then react. And so, and there's a well-defined normal range, and there's a well-defined variability around, repeat measurements. And if it changes by more than 4 points, it's clinically meaningful. And that it doesn't take too long to do. And there's now automated ones, there are online ones, and there's ones that have been done on an iPad, for example. But again, it takes time, and a lot of neurology centers, MS centers, they just don't have that time or the inclination to do it. So I don't know what the solution is to this. My recommendation is for people to self-monitor. There's a whole lot of things people with MS can do themselves using various apps or online resources, and they can monitor their own worsening and then bring the results to the clinician. That's one way of doing it. But before doing self-monitoring, you need to make sure your healthcare professional is going to respond to that information. I've got examples of people, quite obsessive, measuring everything, how far they can walk, their walking times, their 9-hole peg tests, they're doing their cognition tests and everything, and they take the information to their healthcare professional and ignore it. And that's not good. That's very disheartening for the person with the disease.
Yeah. That brings us to shared decision-making. So how important is the patient education and shared decision-making in the management of smoldering MS, and how realistic is it? Because you just mentioned the example, which I bet it's not just from one patient, but probably a few patients were talking about that they were monitoring, brought it back to the physician, and the physician was just ignoring it.
That's essential. I mean, I just don't think you can manage chronic diseases, MS, rheumatoid arthritis, various cancers, without shared decision-making. At the end of the day, it's a partnership. Nobody should dominate that partnership. And, I just can't, it's very difficult to imagine managing somebody who's got MS without at least having shared decision-making. And particularly now that the young people, there is a generation of people where they will accept the paternalistic medicine, where the doctor knew everything and they don't want to know about it. But I think that generation is not there anymore. And, most young people who develop MS are very informed about their disease and often know more about their MS than their neurologists. I'm not saying about more than the MSologists, people, but they often know more about MS than general neurologists. So this is another thing that people with MS can do, is actually train their neurologists about MS. It happens all the time.
I like that one, yes. Okay, so what challenges do patients with smoldering MS commonly face, and how can a multidisciplinary care team address their diverse needs?
Yeah, so I suppose, I was going to give your audience a hint, is there are tools available online to help you prepare for your annual or your 6-monthly follow-up consultation. And if you are self-monitoring and you're detecting that you're worsening, what you should then do is you should potentially send your questions or your information to your healthcare team before your appointment. And you should prioritize maybe 3 things that you want to deal with there and then. Because, I know that, follow-up consultations, even in Germany, are really quite small. They are usually about 15 minutes. And it's really impossible to get through 10 items in 15 minutes. So it's best to get through 3 items well, rather than try 15. And it's up to you to prioritize those. And a lot of them you can actually address yourself using online resources, for example. Sometimes they need to be, the ones that you want to approach your neurologist or your MS nurse with are things that potentially require medical investigations and interventions. So it's actually engaging with the disease, self-monitoring, preparing for consultations, and doing as much online and self-management as possible. I say this, though, self-management takes time to get into the right mode. It doesn't happen in year 1, year 2. It takes a long time for somebody to feel competent or confident enough to self-manage certain problems. But there's much you could do yourself. To give you an example, bladder infections, for example, there are lots of MS patients can do before they get to seeing a urologist or seeing their MSologist about recurrent bladder infections or bladder problems. You can do a lot yourself. Same with constipation. Same with falls and falls prevention. Same with bone health. Same with exercise. There's lots of stuff you can do yourself without necessarily hassling your healthcare professional. And when you go to them, you say, this is what I'm doing myself to improve my general health, but I need help with X, Y, and Z. This is what I would like. And there's certain things you've got to get medications for, spasticity and nocturnal spasms, for example. Most of the time that has to be managed with a prescription of an antispastic drug, for example.
Yeah. So you already talked a lot about the impact of smoldering MS on the patient's quality of life. How can we address the psychological and emotional aspects, which are very important? Because if you are depressed, you don't do much, and then you don't exercise, and then you or you feel lonely, or you don't feel worse having a better health care. So how can you address these problems?
Well, I think awareness. Just being activated and just being activated as a patient, in other words, engaged with the disease and not ignoring symptoms, understanding actually is empowering and helps. I've got a lot of, I'm not saying it's the majority, a small group of people become expert patients. I would imagine now that you're an expert patient. And before you became an expert patient and were very engaged with your management of the disease, you probably felt scared, anxious, and as you learn about the disease and get more confident about managing, interacting with your healthcare professional, things improve. So that's one of the reasons I tell people, education and getting on top of the knowledge around multiple sclerosis will help you in time. People may find it scary, but it's at some point in time they're going to have to face it. They've got this disease. There's no point in I call it the ostrich syndrome. You put your head in the sand and you want to ignore things, but that doesn't deal with it. And if you really are super anxious and you can't deal with the uncertainty that comes with having the disease, and that is a problem. People with MS are often incredibly anxious about the uncertainty. Then you may need professional help, and that's where you would need a therapist. Either group therapy or one-on-one, CBT, mindfulness, and there are lots of things you can do to try and address the anxiety associated with having MS. But but there's also self-help you can do. There are the online courses for mindfulness and CBT that some patients find very, very helpful, for example. And then when people actually get on top of that knowledge, they also begin to sort the rest of their lives out. So they begin to live a much healthier, and they focus on lifestyle and wellness. And that's the pinnacle when you start actually thinking. Now, wellness is a philosophical construct. It's not just about medical problems. It's about spiritual, environmental, how you interact with the wider world. And, there's no doubt in my mind that people who get to that top level where they're actually focusing on being well as they can, then things change dramatically. So I would say there are 1 in 10 people with MS who get to that level, and you can just see that's transformational. They come to terms with having the disease. They're very proactive in managing their disease, and they often become proactive in helping other people, either through education or, one-on-one counseling or peer support groups, whatever. And then they also transform their lives from a wellness perspective. And it's lovely to see that. But it comes from the position of knowledge. It doesn't come from being an ostrich with your head in the sand. You have to face the disease. And I think this also happens in other disease areas. You see it in people with various oncology cancers, for example. It's those people who get on top of the knowledge around their cancer. They have, they often say, I may only have 4 or 5 years because I've got a terminal cancer, but those 4 or 5 years were the best years I lived because I felt that I was, from a philosophical perspective, on top of my disease, and I knew exactly what was going to happen, and they dealt with the uncertainty very, very well.
Yeah. Makes sense. Yeah, absolutely. And of course, I was, I was shocked and scared at the beginning of my 20s when I got the disease, and doing everything, yes, but when I really dive deep into multiple sclerosis with this MS master's program, I felt like really, okay, now things can happen. I know what to do, where to go if things would happen, but I'm fine. I'm fine with it.
Have you learned about, I don't know how popular it is in Germany. There's a thing called Overcoming MS program. Is it popular in Germany? OMS?
I don't know how popular it is. It is known. You mean the one from Australia, right?
Yeah, George Jelinek evolved. Now, it's it's what I would call the ultra distance version of running of lifestyle and wellness. I don't buy into the diet because I think the evidence base for the overcoming MS diet is incredibly poor. So but the rest of the philosophy in the overcoming MS program makes a lot of sense. It's like focusing on wellness, but again, it's not an alternative to disease modifying treatments. It's complementary. In other words, it should be used in combination with disease modifying therapy. And a lot of the overcoming MS people who follow the program often think it's an alternative therapy, but it's not. So the important thing is that's kind of like a good guide to the extreme lifestyle wellness program you can put in place to manage your MS. With the caveat, I think the evidence for the diet is very poor. I wouldn't suggest the diet necessarily, but all the other things I would suggest really make common sense, to be honest with you.
The episode before this one was just on the Mediterranean diet, where there is a lot of evidence that it is healthy direction, adding a lot of fruits and vegetables and all that, but not being restrictive, just going into the direction of the Mediterranean diet. Would you agree?
Yeah, I think the evidence-based Mediterranean diet in terms of cardiovascular health and then brain health it makes sense. But the other side of the thing now is diets are also very important culturally. You know what I mean? It's eating and having meals and having rituals around festivals is a family thing. So, if you're going to go on a diet that restricts your interaction with your family and friends because it's a very strict diet, then that's not the right diet for you. You know what I mean? So I think I've written on my MS Selfie thing a thing about my philosophy around diets. They have to be culturally respectful for traditions. You shouldn't go. As soon as you start eating a diet that stops you having dinner with your family, that's not good.
Yeah. Yes. Yeah. Yes. I probably would get divorced if I restrict meat, for example, and I prefer to stay with my husband. He's a lovely one. So
yes, I mean the evidence that meat is bad for you is very limited. To be honest with you, it's and when you actually do the meta-analysis, what is probably bad for you is certain processing, particularly ultra-processed foods and meats. So if you're going to eat meat, I would say eat, and that's another thing about food. You've got to be mindful in terms of the environment, and just to give you an example, some of the vegan diets that are out there, they are so ultra-processed. They probably very unhealthy for you if you eat the ultra-processed vegan diets. And also vegan diets, you've got to be very mindful of the fact that they are deficient in many things. So you have to then take supplements. So, there's no, every diet's got its quirks. I suppose the Mediterranean diet is the one that we like to promote because it's got this association. I don't know if you're aware though, Mediterranean diet was actually part of a marketing campaign for olive oil companies. And so
they did good.
Yes, they did good. So, the Mediterranean diet became very popular when olive oil started to become popular, and there is a marketing campaign around it supporting both olive oil and red wine. I think was also linked to the Mediterranean diet. So yes, it makes sense, but if you don't eat the Mediterranean diet, I wouldn't be too worried about that. I think just make sure you cut out or reduce as much as possible ultra-processed foods.
Yeah, the ultra-processed foods, that is really important. And we have a nice app here in Germany. I think it's in whole Europe, UCA or something like that, where you can check on the barcode, and then you see you get a 0 to 100 points. And I checked for some of the vegetarian or vegan alternatives, and they were like, wow, horrible because all these things were inside. So I preferred to stay with something where there was, I don't know, let's say the normal, is it hummus in English? How do you call it? Yeah. And of course, other things, but not the processed. So adding, eating the meat, but not the sausages, for example, is better.
Yeah, so Michael Pollan, who's a US journalist, anybody who wants to read his books, they're really quite good. He talks, he writes a lot about food And, he would say, even though fermented foods, like, various breads and that are processed, but they're not ultra processed because you know what goes into them. So if you are going to eat it's best not to eat ultra processed bread, but to eat just fermented processed bread. It's more expensive, and that's one of the things about healthy eating. It's actually, in the current food environment, it's actually more expensive to eat healthily, simply because the processed food, the ultra processed foods, are cheaper, and that's another problem. Is when it comes to social determinants, if people are on low incomes, for example, they can't afford to eat healthily, simply because the cheapest foods on the market are ultra processed foods.
Yeah, that's something hopefully will change at one point in the future, but I'm not sure. Yeah. So we talked we talked quite a lot already about that. How can healthcare professionals collaborate with patient advocates and support groups to enhance the awareness of smoldering MS? Because I know it's very clear in the MS community, but I think it hasn't drawn down to all the patients yet.
Yeah, so I think it's important that MS patients aren't gaslit. So this has become something I became aware of in the last 2 years, actually, is that often people with multiple sclerosis complain about a certain symptom and they get ignored by their healthcare professionals. So I think it's really important that healthcare professionals do not gaslight. In other words, do not ignore or play down symptoms of smoldering MS. They should acknowledge it, document it, and just say, this sounds like you've got smoldering MS, and then have a narrative. They need a simple story to tell patients what's happening to them. And I think people with MS will accept that. So there's obviously a two-way street in terms of educating both healthcare professionals and people with the disease about this concept, and maybe it can happen together. So I think it's still, the concept of smoldering MS is, well established in experts, but in the general neurology field, a lot of people might not feel comfortable discussing it, and that's an education thing. It'll happen over time, particularly once treatments become available, because I suspect, once we get the BTK inhibitors, for example, then there'll be a lot of education around the drugs and the concepts about why these therapies should work or who's eligible for them. So there will be I think a rapid educational, rise in knowledge around smoldering MS over time. But I mean, most healthcare professionals probably realize that it's more to managing MS than the once or twice a year consultation. There's a whole lot of stuff that should happen in between. It's a continuous process, keeping people up to date on new developments, on every time they have their therapies, and there's lots of interactions that can be used intelligently by healthcare professionals and the MS centers to educate patients. So I don't know what treatment you're on, but I mean, you may be going up for infusions every few months or 6 months or whatever. So there are touch points where I think healthcare professionals should educate people with the disease about their disease, and that can be done using peer-to-peer support groups. They work in some hospitals. The people that do the educating is not healthcare professionals, but volunteer people with the disease, for example. It all depends what healthcare system you're working in, if you've got the means to set up these systems.
Yeah. Okay, Gavin, so let's move on to the quickfire Q&A session. Complete the sentence. For me, multiple sclerosis is?
A curable and a preventable disease. How's that sound?
Yeah, I know you promote, and I'm really looking forward to your, let's say, next moves, or you already moved into that direction where you want to try to, cure it or prevent it. Let's see. Would be lovely.
I'd have to do another podcast with you on prevention.
Of course, you are always welcome. And I have 2 girls, so they have a little bit higher chance. So I'm personally very much interested in that topic. Very egoistic. What development would you like to see in the field of multiple sclerosis in the next 5 years?
Well, I would like to see combination therapy trials and a trial design that the regulators accept for combination therapies, because there's 2 problems: is actually doing the trial, in other words, funding it, but also getting the regulators to accept the outcome. So they're going to have to accept the biomarker outcome. So because otherwise they become too big and expensive to do. So that's what I would like to see, is a framework from a regulatory perspective for doing combination therapy trials to target smoldering MS. That's it. Yeah.
Mm. Yeah, and this will be then another challenge to get it paid, right? It'd have to come down probably a little bit in the costs. Let's see, because it will be expensive if you have combination therapy.
Yes, but a lot of the current DMTs are coming off patent, so they are biosimilar generics emerging. So the price of the anti-inflammatory ones will come down as they come off patent. So I personally don't think we should necessarily let the price dictate.
No, absolutely.
And the pharmaceutical industry usually charge what the market can withstand. So they charge too high a price, payers won't pay. So there is kind of a self-correcting system. I know it doesn't work as well as it should work, but at the end of the day, the healthcare systems usually are prepared to pay what they think the drug's worth in terms of its effectiveness.
That's good. Okay, so finally, what message of hope or encouragement would you like to share with the individuals living with MS?
That we've identified a component of MS that the MS community is now targeting. So this is smoldering MS. So there's going to be an era where we're moving into much more effective therapy. So I think going forward in the future, the majority of people with MS are going to get to old age not disabled, and I think that's going to be the real thing that benefit. And then, as I said in the beginning, I do personally think that MS is a curable and preventable disease, and we just have to be brave enough with our upfront treatments to cure the disease. So a lot of people don't use the most effective therapies, first line, and I think we need a shift in emphasis there. That's a whole can of worms. How do we get people to use the most effective therapies up front?
Yeah. So finally, how and where can interested people follow your research activities?
Yeah, so I have a thing called MS Selfie. It stands for MS Self Management. Now there's a newsletter that's on Substack. They can register for that, and then there's a microsite that's a curated site for people to. That's more for self management. So I put up, over time, I usually do one or two newsletters a week. And if people follow MS Selfie, I will always give them the best. I always give them research updates on that. I also try not to overload them with research, because a lot of research is derivative. In other words, it's repetitive. But I will cover all the new highlights and the hot topics on that if they want to. And they don't have to pay. So there is a paid subscription component to that. They only have to pay if they want to ask me questions and answer questions that are not related to my newsletters. And I feel, and the reason why I get them to pay is because I use the money to support the initiative. I've got to pay a medical writer who's doing and I've also got to pay for a web designer and pay for the platform. So, and if people want to actually subscribe and they can't afford to pay, I'll give them a free subscription. So it's like give and take. But they only have to pay for access to the question and answer session that people with MS ask me questions. That's all.
Fantastic. Yes. And I can absolutely recommend that newsletter. I'm a subscriber, and I used your info cards for the DMTs when I was talking about the DMTs, because they are really helpful, just giving that short overview and not the long version. I mean, I explained the long version, but having that short overview is really lovely.
Yeah. So I mean, one of the good things that's come out of the fact that it's now in self-funding in a sense is that I produced the first volume, which you can download from the MS Selfie microsite. It's volume 1 of the self-management guide, and we've got 2 more volumes planned. So this was about disease-modifying treatments in the disease, and people can download that. And they can print it out if they want, or use it as a PDF. And the second volume is going to be about symptomatic treatments, how to manage symptoms. And the third volume is going to be about other things, like brain health. But I think there's going to be enough material on the self-management guide to have 3 volumes. So it'll be quite a big, and what people should also know, Nell, is that I don't dumb it down. So one of the things I have had from people with MS is they find the MS Society and the MS Trust that they write at a very, very low level. So the MS Society in the UK writes for a 12-year-old, That's their rule. So it's actually the lowest common denominator. I tend to treat people with MS as thinking adults that are intelligent, and they can ask questions they don't understand. And so I write at a much higher level. So people must be aware that some of the stuff I write may be difficult to understand, but over time that people begin to understand things and they can ask questions. But I think we have to, at the end of the day, people are going to have to develop a whole new vocabulary. They have to understand the science, and I try not to pull back on the science. Would you read it? Do you understand all of them, or some of them?
Yes, it's just too much with two little kids. So let's say when there is Christmas or some other days off, then I read through the last weeks.
Okay.
So right. I understand it, and it's very interesting because you always make it very personal because you have that one person asking that question, and then you go down the road with on that question, or talk a little bit about the BTK inhibitors, of course, or some other news. It's just a lot because I'm always trying to stay, let's say, a little bit on top of the AI movement because it's also interesting, and
I did an AI
some other aspects in life. It's not the only newsletter.
I did an AI post today because I do think AI is going to, at least in terms of information exchange, is going to just revolutionize medicine. It's really doing it, actually. People aren't aware of it. It's happening already.
Yeah. And I will have some podcast guests on that as well because it's really important, and it helps with shared decision making, especially if you don't have an MS specialist sitting in front of you or somebody who has that patriarchic view. So, Gavin, thank you very much. We already said that there will be a second podcast. Looking forward to that. Thank you very much for being here for the first time and looking forward to the next one and for giving all that insight, information, and hopefully helping to raise awareness for the smoldering MS. And
okay.
See you next time. Thanks a lot.
Take care.
Bye-bye.
Have a good evening.
Bye-bye. You too. I hope you enjoyed the interview and learned something new, especially about smoldering MS. But there were also lots of topic on the side, and I think it's always really worth it listening to Gavin Giovannoni. By the way, next time I will be having a ECTRIMS special again, and this time on sleep disorders and papers that were presented at ECTRIMS in 2024. So please tune in again, recommend the podcast to whoever might be interested in it, rate it wherever you are listening to it, and stay as healthy and positive as possible. See you next time. Bye. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.